So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and you're listening to another episode of the Pharm So Hard
Ambulatory Care Podcast. All right. Welcome back to another episode of the Pharm So Hard Ambulatory Care Podcast. And today we are hopping into episode 2 of our Women's Health series. We just did an overview of contraception, all of our various options. And today we're talking about a pretty cool topic, which is pharmacist prescribing of contraceptions. And I find this topic very interesting because it has a lot of the same nuances as when pharmacists were first being considered to give things like immunizations for the first time. So I think that's pretty cool. One resource I definitely want to highlight if our viewers aren't aware of it, for our pharmacists, our providers, anybody who's listening, is the Birth Control Pharmacist. So their website is birthcontrolpharmacist.com. They have a lot of great resources that we'll be referencing and talking about throughout the episode today. So if you are looking to get into the women's health space or get more information about it, you should definitely go check them out. But I think we'll start with just some background and like why this was important, how pharmacists kind of got involved into this space. So Micaela, kind of walk us through, why is this even important that pharmacists are kind of involved in this space?
Yeah, it's great to start off with, the statistics and the importance of pharmacists in prescribing contraception. Number one, 89% of Americans live within 5 miles of a pharmacy. So opening up access to care is a big reason why pharmacists are a great healthcare provider to implement and really utilize in this space. And this was provided by Pharmacy Times when I looked into it just to verify. This just shows that we're a perfect bridge to bridge this gap in care, basically. And then when we think about ourselves as women trying to get into a doctor's appointment for any kind of healthcare related appointment, that can be a huge barrier. So we looked into barriers for women trying to get access to hormonal contraception, and 23% was a difficulty in obtaining appointments, which I've definitely seen as a patient, and I see even with patients in the clinics where we've worked and where I work currently and where I've worked in the past. It's just really hard to get space in a clinic as a patient. And then number 2 at 14% was cost or insurance barriers. Number 3 at 13% was an examination or a pap smear requirement being part of it. And then number 8 was, or the fourth one was at 8%, and it was other. So really just pharmacists give us options in this space. They play a crucial role in improving access to care relating to contraception through various protocols and agreements, which we're going to talk about next. So when you think about it, you could have different ways that pharmacists could be integrated into giving patients access to hormonal contraception. One being a state protocol, and this basically authorizes a pharmacist to prescribe independently. I originally got licensed in North Carolina, which is where I was born and raised and first practiced. And then I recently got licensed in South Carolina with my job in transplant. And as I was going through the law exam and studying for the NPJE, I saw that they use a state protocol for hormonal contraception. And basically, this is a significant step forward for pharmacists. It allows them to use their expertise and access their patient needs and provide contraception without requiring a prescription from an alternative provider, right? They can meet with a patient and prescribe what they need from a contraception perspective. And we're going to talk about what all that looks like a little bit later. But for example, states like California and Oregon have implemented such protocols successfully, and they've demonstrated an improved access to care for contraception and positive health outcomes. And then the second way we could integrate pharmacists into prescribing contraception for patients or in this space is by using a standing order. And this is basically where a state health officer authorizes a pharmacist to prescribe if they meet the training requirements. And this basically involves the health officer, and it can align with the bigger overarching public health goals by having this piece. And an example of this is that North Carolina utilizes a standing order for pharmacists to dispense hormonal contraception, increasing accessibility while maintaining quality through the required training with this standing order. And then another option we could do is be in a collaborative practice agreement. We've talked about this on other episodes, and this could be either population-based or patient-based when you're in an agreement with a provider or a group of providers. And an example of this is like in New Mexico, they have collaborative practice agreements that have enabled pharmacists to offer personalized contraceptive services, working closely with primary care to optimize patient outcomes. So now I'm going to throw it back to you, Morgan, and walk us through the historical context relating to this topic.
Yeah, you mentioned a couple of states there that we'll talk about in just a second, but I think it's important to kind of go through the different types of agreements or protocols or things that states can practice under, because it can be different between each of the individual states. And we're not going to go through every state, obviously, and talk about which state has, but it can be a little bit different. So every state has their own legislation that determines, what they're practicing under kind of like immunizations. Again, it's a very similar process. Some states have protocols, some have, collaborative practice agreements. It just kind of depends. But really, the prescribing of contraception by pharmacists started all the way back in 1998, and that was in Washington State. And then we kind of had a big gap until about 2016 when both California and Oregon then got legislation to allow for this as well. So really, it's only been within the last 8 years that a lot of this development has really started to snowball, and we've seen a lot more activity around this particular topic for pharmacists. But there was a lot of good studies that came out of Oregon specifically within the first 2 years that they had this legislation, and they actually had the ability for pharmacists to offer this service. And so within those first 2 years of pharmacists being able to prescribe contraception, 46% of pharmacies in Oregon offered the service. And I think that's pretty insane that very early on, a lot of pharmacies actually did want to participate in this service. And I think that's a model to some of the newer states that we have that have jumped on to being able to offer this in their state. But one of the significant things is that 74% of patients who in the first 2 years had contraception provided by a pharmacist had not had access to contraception within the last 30 days. And so that's very largely showing this gap that pharmacists were able to fill for these patients. And of the patients that got prescribed contraception by a pharmacist, 36% were from a rural location or a rural area. So again, we talk all the time about meeting this need for rural or lower income areas. And so we now have data to kind of back that up, that that's exactly what it did. Because sometimes we think that, some of our interventions are going to meet a need or meet a specific population, but maybe they don't always. So it's nice to see the data kind of back up what we thought would happen. And then during those 2 years, 10% of all Medicaid patients that were given a prescription for pills or patches were written by a pharmacist. So again, overarchingly talking about patients who received prescriptions, 10% of those came from a pharmacist, which is pretty cool. So where does that leave us today? Because that was all the way back in, 2016. So as of today, we have 29 states that have some sort of legislation that authorizes pharmacists to prescribe contraception. The newest are New York and New Jersey that were added here in 2024. So even, we're 7 months into 2024, we're still having states being added. On the docket that have pending legislation, Connecticut, Delaware, Maine, Massachusetts, Rhode Island, and Washington, D.C. are all in progress right now. So I guess most of the North are kind of getting their feet into this space as well. And so it's just going to further expand so that several more states that we can add. So we're over 50% of the United States having pharmacist ability to provide this service, which I think is a significant improvement, because I think when I talked about this last year, we were only at like 25 or 26. So we've already added some in that short amount of time.
Yeah, that's super interesting about how on board pharmacy was when you were talking about, that 36% in the rural locations and then 74% of patients prescribed by a pharmacist. That's awesome. When we progress in our abilities, I feel like sometimes things get put on community pharmacists, and I feel like it's not always fair to them, what they have to manage and do. So I hope that was a positive thing, and maybe they were able to take it on happily instead of it being another metric that they were having to do in addition to all their other responsibilities. But what have you seen anything with that on like people starting it in the clinic versus having to do it in the pharmacy and maybe it like really disrupting workflow? I really haven't seen a lot of pharmacists integrate that yet.
Yeah. So, and I mean, that'll be one of the things we talk about too, in one of our segments where we talk about like safety and then also considerations that are talked about when we think about like the actual feasibility of putting this into a pharmacist practice. But I think, especially when I thought about like South Carolina, they got this legislation, because that's what really deep dove me into this topic, was when that was passed in 2022, was a lot of independent pharmacies were really like passionate about it. They were like, yeah. And it was like, well, your workflow is very different than that of like a retail pharmacy. And you might have the space physically to be able to do this that maybe a retail pharmacist doesn't have, or the time to do this that a retail pharmacist doesn't have. So I think it's different from all aspects of outpatient care, whether you're in ambulatory care setting, an independent pharmacy, or a retail pharmacy. That's really going to determine your ability to take something like this on. And so we'll talk about that a little bit later.
Yeah, that's great. I think about my history working in Walgreens and Rite Aid in pharmacy school. And I was like, if I had to go step out to counsel a patient as a pharmacist, that would, for like 30-minute visit for contraception, that would really throw a kink into the workflow. So I could only imagine. Excited to talk more about it. But next, I kind of want to talk about the safety and considerations that we need to think about. So can you walk us through the safety aspect of this?
Yeah, I think the biggest safety concern, when you talk to OBGYNs or you talk to other providers about this is, the ability to properly screen patients for appropriateness of being on a contraception. And I think that really revolves, again, like we talked about in the first episode of the series, around the estrogen containing products. Are we going to be able to, in a busy community pharmacy setting, maybe be able to triage people appropriately and understand who would be a good candidate for what, and all of those various things. And so the main tool that's even used in OBGYN offices is something called the U.S. eligibility criteria for contraceptive use. And so a lot of times this is patient administered as a tool for assessing the safety of prescribing contraception, mostly in mind thinking about like estrogen containing products. And so there's actually been a lot of studies done on patients' ability, or women in particular, their ability to self-screen themselves for their appropriateness for contraception. And I don't think it even really stops at, estrogen containing products, but then being able to recognize when they may or may not be at risk for pregnancy. Could they be pregnant? Could they not be pregnant? Do I need to get a pregnancy test? Things of that nature also are of concern when prescribing somebody contraception when you maybe don't know or are not sure if they're pregnant. So I think it's really reassuring that a lot of studies have found that women are more than capable of self-assessing themselves to determine that. But I think also when we talk about safety, many states have a standard procedure algorithm included in their legislation, or very soon after legislation is passed. So, for example, South Carolina, when they passed this legislation in 2022, part of the legislation stated that a standard protocol or algorithm had to be developed within 6 months of the legislation passing. And so that was a collaborative effort from the Board of Pharmacy and the Board of Medical Examiners to come together as almost like a little task force and develop that as a whole. And so what I find funny is I was able to go to some of those meetings when they were developing the protocol. They very, very similarly aligned their protocol with Virginia, which is where I now practice. So I found that funny that they're pretty much identical because they didn't want to reinvent the wheel, right? There's other states way before them that have done this, done it successfully, done it safely. And so I thought it was really cool to see those discussions. But again, from a safety standpoint, we talk about what options are allowed for prescribing, and it's going to differ state to state. I will say South Carolina and Virginia, I was actually surprised that South Carolina was so broad and lenient with the options that were allowed to be prescribed by a pharmacist. I would consider South Carolina to be more conservative and maybe not as progressive when it comes to pharmacist authority or pharmacist prescribing. So I was pleasantly surprised to see that, in South Carolina or Virginia, you pretty much do anything except for the Nexplanon implant or an IUD. And that makes a lot of sense because pharmacists are not trained to perform medical procedures, nor would we want them to be done probably in a community pharmacy setting. So that makes a whole lot of sense. There are some states that are a little bit stricter and they say, oh, only the pill. There's some that say you can do like the pill patch ring, but not the injection. So it differs from state to state. So again, the birth control pharmacist website, they have a great table that outlines every single state that has this legislation, what's allowed in every single state, what they practice under. Is it a standing protocol? Is it a CPA? Like, what is it? So they have a really great table for that if you're interested in it. But to your point about like retail spaces and privacy, how, especially in your CVS, Walgreens, wherever, that's a concern, right? Like, how are you able to provide this service in a HIPAA compliant space, in a private space, when you're talking about probably a pretty intimate topic? And part of the conversation and assessing if a patient is appropriate for contraception is asking about, sexual history, sexual activity, their possibilities of being pregnant. Those are some pretty sensitive topics. And so to have that potentially in the middle of a Publix, that is in the middle of a grocery store. And from my experience, working at Publix, it wasn't like a CVS where they had like a minute clinic kind of area. There literally was no like kind of patient privacy area. Even when we did immunizations, you just kind of opened the door, had them stand up by the door, and you just kind of like gave them their shot and they walked away, and that was about it. So thinking about implementing something like this and this sensitive of a topic for a lot of people, that's a consideration to have.
Yeah, definitely. I would not want to go to a grocery store, pharmacy, or even just like a normal retail pharmacy to get any of that work done. But, I'm sure I really like the idea of independence, integrating this into independent pharmacies, because they could come up with a great workflow, just like you were talking about, where women can, you basically give them a checklist is what I'm thinking, and they go through all these steps. And then once they've done all that, then they come to you. You spend 30 minutes in the consultation after you've reviewed their workup, and then, go from there with the prescribing of what's best for them and their needs. So that's really cool. I think what I'm going to talk about next is basically what happens afterwards, or how we can integrate this from a holistic practice, right? We're not doing the routine care. So pharmacists in this space need to keep in mind that it's important to ensure that patients obtain appropriate referrals for routine care when prescribing contraception. So this could include pap smears or annual women wellness visits, mammograms, STI screenings, pregnancy tests, etc. And then this really is a good space for us, right? Because we can do what we need to do with our expertise in counseling and really going through the patient's history, but then outsource what we need to do as far as the referral space. But we have to make sure that we have a good system in place for that, with an accessible provider, and to encourage and have a system to have checks and balances to make sure this happens. A lot of this stuff is in the standard protocols. Like I know with South Carolina, you have to have adequate documentation that they've actually done these referrals that they have in place before you can move forward in this process of prescribing contraception. And then payment for service. We talked about this before, but reimbursement has been a major issue for expanding the role of the pharmacist into areas just like this. So this is definitely a limiting factor for full integration of pharmacists into prescribing hormonal contraception. There's been a lot of progress made. Many states now include reimbursement criteria within their statutes. This could be, for an example, Medicare coverage is ensuring pharmacists are compensated for their time and expertise. But it's crucial for sustainability of these services, number one, and for the ability to keep this pharmacist employed, number two. We have to be able to reimburse for this, for the services that we're providing, to be able to sustain the job for the pharmacist. An example is in Oregon. So their average time that the pharmacist would spend counseling and prescribing contraception was about 30 minutes. And it really helped to demonstrate the feasibility of incorporating pharmacists into the service. And into routine pharmacy operations. But that's the number one key here, is ensuring adequate reimbursement, not only to help with the workflow and management of the pharmacist. I mean, if you had an adequate reimbursement model, then you could hire another pharmacist into your pharmacy to be someone who kind of helps out and then steps away to do the contraception visits. That's just the major piece there.
I agree. Because, I mean, I think the main thing from a pharmacist perspective is like, how the heck are we going to do this, especially post-COVID times? Like, let's talk about that. Like, think about the huge undertaking that pharmacists undertook during the COVID pandemic with just immunizations, providing COVID tests. I mean, all the things that did, in addition to just being a pharmacist in a normal workflow. And I think this is also occurring in a time where there's a technician shortage from, lack of being able to pay them appropriately for the work that they do. And they work so hard, and that's coming from me. I was a technician myself. I was an intern myself. So I know all too well, how hard that they work. And so we love our technicians, but when a pharmacist is spending on average 30 minutes providing the service, which I think is a great service and can meet the need for a lot of patients, what's happening to the prescriptions, what's happening to the drive-through, what's happening to the patients who need to get counseled on the prescriptions that they're picking up. The technicians are probably being burnt out by, some of that workflow burden that they're going to have because of that. And then if you're not being reimbursed for providing that service that's taking up 30 minutes at a time, to, maybe hire more technician help, hire another pharmacist to, watch the pharmacy while you're providing these various services. That's going to become really, really difficult. And I think it leads to the overall conversation of pharmacists being appropriately paid for their services in general, but especially if it's going to take up a significant part of the workflow, that's something to consider. And I think that's the thing that makes a lot of pharmacists hesitant to provide this service. And, when it was going on in South Carolina, that was a conversation that a lot of people had amongst like the pharmacy associations and stuff like that. When it was just a bill and it hadn't been passed yet, was the concern about like, okay, but how am I going to do this? And nothing in this, at least in South Carolina, like nothing in the bill or in the law now forces pharmacies to participate. They absolutely don't have to. But I think the cool thing that South Carolina did that a lot of states are doing now is it includes some type of language that requires payers or insurers to cover any pharmacist provided service specifically for contraception. And so I think that's important for future states moving forward, or even states that already have the legislation that maybe would like to amend that legislation to go back and make sure that language is included, that pharmacists are being appropriately paid for their work that they're doing.
Yeah, this just opens up a great conversation to, again, talk about reimbursement for all the different services that pharmacists can provide with their knowledge and expertise and access, patient access. They're in rural areas. The closest thing they have is a pharmacy, and whether it's independent, retail, or whatever, they need another healthcare provider to step in and really open up the ability to be able to get in the door for a patient. In the whole grand scheme of things, that's what we're trying to do. We're not trying to step on any toes or take something away from another provider. We're trying to add to the provider so they can spend, more quality time with their patients and potentially reduce their provider burnout and burden overall. So I think it's a great conversation.
I think that's funny because I literally had a conversation today at work with a provider. She came to me about none other than weight loss clinic and our GLP-1s. I can never get away from it. But she voiced interest specifically about having a pharmacist in her weight loss clinic. And she does a lot of telehealth along with that. And so she was asking me, she was like, "Oh, do you bill right now?" And I was like, "Actually, no, I don't. It has to do with the way that my institution's billing is like set up, but pharmacists at my institution as of right now do not bill for their services." She goes, "Wait, so when you see patients and you manage all their meds and you do all that," she's like, "you're basically providing a free service?" I was like, "I mean, yeah, pretty much." So she was really shocked to learn that. And she's like, "I feel like that's just so crazy. That would be beneficial for all people involved." And, even for her as a physician that's been practicing for so many years, that was so shocking. And she was like, "I can't believe you basically like work for free, quote unquote." I was like, yeah, that's just kind of how pharmacist billing is in our world right now, until on a federal level, we're recognized as providers.
Exactly. Yeah, we don't bill for our services either. It's just, they eat the cost of us, but they really see the value of it. Obviously, they wouldn't pay a pharmacist's salary for it. So it's just crazy to me that Medicare sees the value. I mean, we're required to be on transplant teams as pharmacists to prevent, negative outcomes, hospitalizations, making sure everything's going to plan for these transplant patients. You would think commercial payers would follow suit if Medicare's trying not to pay extra money by hiring a pharmacist. They would see the value and follow suit, but we're just waiting on that to happen.
Maybe next year.
Yeah, exactly. I remember talking to professors in pharmacy school, and they're like, we've been talking about provider status since I was in pharmacy school, and they would be,
20 years.
Yeah, exactly. And they're like, I'm like, where do you see provider status going in the next 10 years? They're like, well, it's been like this for the last 20 years since I was in pharmacy school. So I don't know. That's sad.
We'll get there. It takes people like us rooting for it to go. All right. Well, that concludes today's episode. So we're just going to kind of summarize here what we think you should really take away from this episode today. Really, that pharmacist-prescribed contraception, it's safe and it's actually evidence-based. We have a lot of data thanks to places like California and Oregon for really looking in the beginning years around like 2016 to, find out what the actual feasibility and the implementation of strategies like this was going to be. So it's really nice to have that. And we can clearly see from that data that pharmacists can decrease health disparities, specifically in rural and low-income areas, which is really the communities that would benefit the most from pharmacists being able to participate in this kind of protocol or system. And I think that really not only location wise is why that happens, but I also think, pharmacies, they obviously have longer service hours and then maybe even more convenient locations. But those are some really, really great reasons why pharmacists should be provided the opportunity to at least participate this. But this all comes down to really fair reimbursement rates, pharmacists getting reimbursed for the services that they're providing, that then will lead them to be able to use those funds to hire more technician help, hire for more pharmacist help for more of their like dispensing workflow operations, to be able to maybe not even just provide more of the contraception services, but maybe towards the future, more things that we talk about, like point of care services, like strep throat testing, or, more diabetes or hypertension management in like a community setting. And so really reimbursement is kind of where it starts and leads to other opportunities down the line.
Yes, definitely. I really want to encourage our listeners, anyone, who's following along, to consult with a healthcare provider about personalized contraceptive advice or contraception advice, or, try to look into pharmacists who are working in this space and get more information from them, or reach out to us. We'd love to help you in your journey if this is something that you're very passionate about, like Morgan. And I want you to continue following along. If you love women's health and you're really excited about what we're talking about, we're in a series right now. So join us next episode on our women's health series. And don't forget to like and subscribe so you never miss another episode with the Pharm So Hard Ambulatory Care podcast. Leave us a comment and join in the conversation. If you're interested, check out the show notes and look into our Patreon. And until next time, we'll see you on the Pharm So Hard Ambulatory Care podcast. Bye, guys.
So I farm so hard, the employees want to find me and then want to hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never gonna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and
you're listening to another episode of the Pharm So Hard Ambulatory Care podcast.